Bismillah ar-Rahman ar-Rahim. I welcome you all to this PSPCon 2024, day second. Our first session is Acute Medicine Expanding Horizons for the Future of Internal Medicine. We have distinguished seniors for for this session as chairs. I will first request Professor Khalid Mahmood to have his chair. Our second chairperson is Professor Ziauddin. He's head of Medical C Unit, Led Reading Hospital, Peshawar. Our third chair is Professor Dr. Abdur Rahman. He is ex-associate professor of medicine, Led Reading Hospital, Peshawar. And our fourth chairperson is Dr. Salman. He is assistant professor of medicine, Sedu Group of Teaching Hospital, Swat. Our first speaker for today's session is Dr. Naveed Iqbal. He is assistant professor of medicine, Led Reading Hospital, Peshawar. His topic is sepsis management, early detection and intervention.
Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Assalamu alaikum, ladies and gentlemen, and my colleagues and respected teachers. I'm Dr. Naveed from the Department of Medicine, Lady Reading Hospital, Peshawar. My topic is sepsis management, early detection and intervention. In 1991, the first consensus conference agreed to a definition of sepsis, allied it to the concept of systemic inflammatory response. In 2016, the third international consensus definition for sepsis and septic shock, which is called sepsis 3, redefined sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. Septic shock should be considered as a subset of sepsis in which the underlying circulatory, cellular, metabolic abnormalities contribute to a greater risk of mortality than posed by the sepsis alone. Septic shock is defined as persistent hypotension which require a vasopressor to maintain a mean arterial pressure of 65 mg or higher and a serum lactate level of more than 18 mg per deciliter despite adequate volume resuscitation. The incidence of sepsis is continuously increasing since its definition in 1991, and 49 million cases of sepsis and 11 million sepsis-related deaths were reported worldwide in 2017. But I'm sure that the figure must be much more higher than this because most of the cases are not reported from the third world countries. But factors responsible for this increased incidence are the advanced average age among the patients, particularly in the developed countries, the increased number of invasive procedures which are done nowadays, and the widespread use of immunosuppressive drugs and chemotherapeutic drugs. And antibiotic resistance is another important factor. The most common gram-positive organisms which cause the sepsis are Staphylococcus aureus and Streptococcus pneumoniae. E. coli, Klebsiella, and Pseudomonas are among the most common gram-negative. And in patients with immunocompromisation, Candida species sometimes cause sepsis. Sepsis is common in neonates, older adults, pregnant women, and the other predisposing conditions are diabetes mellitus, cirrhosis, leukopenia, especially that associated with cancer treatment and cytotoxic medication. Invasive devices including endotracheal tube, vascular or urinary catheter, drainage tube, and other foreign materials. Prior treatment with antibiotic or corticosteroid, recent hospitalization, particularly in the ICU, and HIV positive patient and IV drug abusers. Well, the sources of sepsis are Sepsis most commonly arises from the respiratory tract and the pulmonary parenchyma in 43% of cases. Urinary tract is the next one with 16%, the abdomen 14%, head and neck, and fever of unknown origin 14%, and other sources contribute 13%. Pathophysiology and inflammatory stimulus, for example, a bacterial toxin, trigger production of pro-inflammatory mediators, tumor necrosis factor, and interleukin-1. These cytokines cause neutrophil endothelial cell adhesion, activate the clotting mechanism, and generate microthrombi. They also release numerous other mediators, including leukotrienes, lipooxygenase, histamines, bradykinin, serotonin, and interleukin-2. They are opposed by the anti-inflammatory mediators such as interleukin-4 and interleukin-10, resulting in a negative feedback mechanism. Initially, the arteries and the arterioles dilate, increasing the peripheral arterial resistance. Cardiac output typically increases, and this time it is called a warm shock. Later on, cardiac output decreases, but blood pressure falls with or without increase in the peripheral resistance, and typical features of hypoperfusion appear. At this time, it is called a cold shock. But even in the stage of increased cardiac output, vasoactive mediator cause blood flow to bypass capillary exchange vessels, which is a distributed defect. Poor capillary blood flow resulting from this shunting, along with capillary obstruction by microthrombi, decreased delivery of oxygen, impairs removal of carbon dioxide and waste product. Decreased perfusion causes dysfunction and sometimes failure of more than one organs, including the kidney, lung, liver, brain, and heart. Coagulopathy may develop because of intravascular coagulation with the consumption of major clotting factors. Excessive fibrinolysis in reaction thereto are more often a combination of both. So, how we assess the end organ damage? A systolic blood pressure of less than 90 mmHg or 40 mmHg drops from the baseline, or a mean arterial pressure of less than 65 mmHg. Bilateral new pulmonary infiltrate with a partial pressure of oxygen to the ratio of inspired oxygen less than 39.9 kilopascal. A serum lactate level of more than 2 millimole per liter, and a serum creatinine of more than 1.92 milligram per deciliter, or a urine output that is less than 0.5 ml per kg per hour for 2 consecutive hours. An INR of more than 1.5 and APTT of more than 60 seconds. The platelet count of less than 1000 per cc cube. Bilirubin of more than 1.87 milligram per deciliter. The symptoms of the sepsis and septic shock depends upon the organ or the system from which it appears. For example, in pneumonia, it will be cough, fever, shortness of breath. However, the general features are fever, tachycardia, diaphoresis, tachypnea, and confusion. Investigation which should be done in a sepsis patient is CBC, CRP, LFTs, liver biochemistry, RFTs, D-dimer, coagulation profile, urine RE, blood culture, and other cultures if indicated, cardiac enzymes, serum lactate, arterial blood gases, procalcitonin, ECG, X-ray chest, ultrasound, and sometimes CT scan and MRI to locate the source of abscess in the abdomen or chest. Well, this is a most commonly used sequential organ failure assessment for the sepsis patient, in which there is a respiration, coagulation, liver, bilirubin, cardiovascular, CNS scoring, and we incorporate these scores, and then it gives us idea about the sepsis and its severity. But a quick scoring system is the Q so far, in which we have a GCS of less than 15, a respiratory rate of less than more than 22, and a systolic blood pressure of less than 100 mmHg. If we have 0 or 1 score out of 3, there is the patient is not at high risk. But if you got 2 to 3 points, the patient is at high risk of sepsis. While coming to the treatment of the sepsis, the cornerstone of the treatment is the antimicrobials. The minutes and hours counts. The earlier the treatment is started, the better is the outcome. Microbial therapy is the cornerstone of the sepsis and the septic shock. The administration of prompt empiric antimicrobial therapy at the time of sepsis identification and after the collection of appropriate cultures is a crucial step. The choice of empiric antibiotic therapy is based upon the clinical, that is the site of infection, previous antibiotic use, immunosuppression, and the risk for the resistant organisms. Typically, broad-spectrum antibiotic, which cover both gram-positive and gram-negative bacteria, is used initially. Patients who are immunocompromised should also receive an empiric antifungal therapy. In general, the common antibiotic for gram-positive organism include vancomycin and linezolid. For gram-negative, we have a broad range, including penicillin, such as piperacillin tazobactam, a third generation or fourth generation cephalosporin, imipenem, and aminoglycosides. Initial broad-spectrum coverage should be then narrowed once we have blood culture or any other culture report at our hand. Source of infection control is very important. IV and urinary catheter and endotracheal tube should be removed if possible or changed. Obstructive biliary tract and urinary tract system are common causes of sepsis. So placement of a common bile duct stent, urinary catheter, or a nephrostomy tube may be required. Abscesses must be drained and necrotic and devitalized tissue must be surgically excised. If excision is not possible, surgical drainage may help. If the source of infection is not controlled, the patient will continue to deteriorate even with antibiotic therapy. The second cornerstone of the sepsis treatment is the intravenous fluids. The effective support of hemodynamic function is essential for the survival of the patient with sepsis and septic shock. Balanced isotonic crystallite is required. Colloid should be avoided because it is said that it may harm the patient rather than beneficial to the patient. Most patients require a minimum of 30 ml per kg in the first 4 to 6 hours to achieve a tissue perfusion without causing pulmonary edema due to fluid overload. Fluid should be given until the CVP reaches 8 mmHg or pulmonary arterial occlusive pressure reaches 12 to 15 mmHg. However, patient on mechanical ventilation may require a higher CVP levels. Pulmonary arterial occlusion pressure or echocardiography can identify limitation in the left ventricular function and incipient pulmonary edema due to the fluid overload. Vasoactive agents, the use of entropic drugs represent one of the cornerstones of septic shock treatment. Surviving the sepsis campaign recommend a mean arterial pressure of 65 mmHg and indicate norepinephrine as the first drug of choice. Norepinephrine is both alpha and beta adrenergic agonist that enhance vascular filling pressure and redistribute blood flow via its vasoconstrictive effect and improves myocardial contractility and cardiac output without a major effect on the heart rate. The dose of norepinephrine is 0.1 to 1.2 microgram per kg per minute. Vasopressin may be considered as a second-line choice for the septic shock treatment. Epinephrine should be considered as a third-line treatment for septic shock, and its use should be limited to those cases with inadequate mean arterial pressure levels despite norepinephrine and vasopressin administration. Oxygen should be started at 15 liters per minute and then titrated to aim for a partial pressure saturation of 94 to 98%. But saturation of 88 to 92% is desirable if the patient is at risk of hypercapnic respiratory failure, such as those patients who are having a chronic obstructive pulmonary disease, obstructive sleep apnea, or others. For a patient who are on non-invasive ventilation or mechanical ventilation, a low tidal volume of 6 ml per kg is recommended. A high flow nasal cannula may be successfully used in septic shock patient with hypoxic respiratory failure. Heparin, since critically ill patients are at risk of deep vein thrombosis and pulmonary embolism, sepsis and septic shock might induce disseminated intravascular coagulation. Heparin should be included in the treatment of these patients. Surviving the sepsis campaign guidelines strongly recommend venous thromboembolism prophylaxis while administering low molecular weight heparin rather than unfractionated heparin. Stress hypoglycemia due to increased glucocorticoids and catecholamine release and insulin resistance is a common effect and may worsen the septic shock outcome. In diabetic patient and in critically ill patient, insulin infusion should be selected over oral anti-diabetic treatment. Since septic shock patients often show frequent variation in glycemic values, the use of careful monitoring strategy is advisable. According to the Surviving Sepsis campaign guidelines, blood glucose targets for a septic patient is 144 to 180 milligram per deciliter. Acute kidney injury may occur in septic patient, which is defined by increase in the serum creatinine of 0.3 milligram per deciliter within 48 hours, or an increase of more than 1.5 milligram from the baseline values within the previous 7 days, or a decrease in the urine volume of less than 0.5 ml per kg per hour. The indication for renal replacement therapy are severe metabolic acidosis, refractory volume overload, electrolyte imbalance, which is not responding to your conservative management, and uremic complications such as pericarditis. Steroids have no role in the treatment of sepsis. However, hydrocortisone may be considered as in a patient with vasopressin-resistant shock with inadequate mean arterial pressure. Sodium bicarbonate should be discouraged. It should be only used in a patient whose bicarbonate level is less than 5 milli equivalent per liter or a pH of less than 7.1. These are some of the references for my lecture, and thank you very much.